So nice to meet any of you who have never been in a session with me before. My name's Jackie. I'm a third-year medical student in Florida. I'm planning on pursuing cardiac surgery following medical school. So this is one of the things that I love to talk about. Very closely intertwined with cardiac surgery and heart transplant in particular is going to be heart failure. So a lot of what we talk about today is going to be related to heart failure, which precipitates the need for heart transplant. So this topic is going to be largely interconnected. But people who know me or people who don't know me, please interrupt if I am confusing, don't make sense, or if I need to say the same thing again. I'm going to stop periodically and ask questions to the group, but you don't have to unmute. I'm never going to cold call because I think it's aggressive. But you guys can just respond in the chat, or you can unmute and talk, of course, but it's up to you. So we're going to get started. This is the session outline for anyone who doesn't have it. We're going to go through the case, physical exam, build a DDX together, go through the assessment and plan, and then talk a bit about the pathology of the disease. Please try to participate. Don't have to, but it's better if you do. And then please fill out that Google form that I sent in the chat as we're going. It'll just make it easier for you. This is what it looks like. I guess I'll just go over it now. I think some of you have been in sessions with me before, but let's just go over quickly what the SOAP note is. Does anyone want to offer up what the subjective bit of the SOAP note will include as terms as when we're going through the case? Or how does subjective differ from objective? Subjective is info from the patient. Exactly, perfect. It is not quantifiable. That's sometimes true. So if a patient says, like, I've had this, I would quantify my pain as like a 5 out of 10 on the pain scale, then that's kind of a way to quantify it. But I guess you could say that it's not going to be numerical lab values, if that's what you're getting at. And that's absolutely true. Errors, you're right. Chief complaint and the history from the patient is all subjective. So now objective, on the other hand, I think Matthew was kind of hinting at it, is going to be, yep, everything we find out during the exam. Yeah, quantified results from the, yes. So basically, subjective is going to be anything the patient tells you, and then objective is going to be our physical exam, our labs, our imaging, and all of those things that we kind of collect that isn't coming directly from the patient's mouth. And then the assessment and plan are kind of one big thing, and that's where we talk about what each of the problems were that the patient's coming in with, and we develop how we're going to attack each of those things. Okay, just want to make sure that we're clear on that, because I think sometimes the concept gets a little confusing. All right, so we have Mr. Murray, who is a 65-year-old male who's presenting to his cardiologist, which is us today, with shortness of breath. The patient reports that he's been feeling fatigued for the past few months and often has to stop and sit down when he's carrying groceries into his house. So this is going to go into which part of your SOAP note? All of these things. Subjective, perfect. Let me know when it's okay to move on into the next slide. I want to make sure everyone has their SOAP note filled out before we move on. Someone just give me a thumbs up, or say, no, don't give a thumbs up because I can't see your little people squares. Just say like done or something, and then we can move on. Alrighty, thank you, Matthew. Okay, I don't know why this slide is empty. Okay, so now, given that information that we've gotten from Mr. Murray, what are some additional questions that we want to ask him? And then I'll answer as if I'm Mr. Murray and you guys are the physicians. You're my cardiologist right now. So I came in and I said, I'm feeling short of breath, especially when I carry in my groceries. What's wrong with me? When did the shortness of breath start? So it's been progressing for a couple of months, and it's just been getting kind of worse since then. But I've had it for a few months. Any other things you want to ask? Things that will be in the subjective part of the SOAP note. COVID? No. Okay. So yeah, that's actually a really astute question. I got a rapid test from Walgreens and I am COVID negative and I've gotten both of my Pfizer vaccines. I'm waiting on the booster. It's the first time you're experiencing the shortness of breath, or has this happened before? You know, I've felt fatigued for a while, but I've felt truly short of breath over the past couple of months. But I haven't had episodes like this before. That's a great question. Have you taken any medications, or do you have anything to alleviate the pain? So I haven't been to my doctor in, decades. I hate going to the doctor. So I don't really take too many medications, and if I do, I don't remember. But I don't go to the doctor very often, and the only thing that really helps is just kind of sitting down and catching my breath. Family history, I think my mom had diabetes. Changes in daily habits? No, not really. I mean, I'm not able to walk as much because I'm short of breath, but other than that, nothing too big that I've been doing. When are the symptoms worse and distress worse than the symptoms? That's a great question for a cardiac, from a cardiac standpoint. The symptoms are worse when I'm exerting myself. I feel really short of breath going up the stairs, and at this point, even like if I stand up from my chair, I feel winded, and it's just been getting worse. I can't even walk across the room without feeling winded now. And sometimes when I'm stressed and I kind of breathe heavy, I feel more short of breath for sure. But it's not really a chest pain, if that's what we're getting at. And the frequent episodes, it's just whenever I move, pretty much. And my day-to-day, I'm pretty sedentary, I'm retired. So, I mostly just kind of sit at home on my easy chair. Oh, please. Okay, so then here's some questions that I had put just for us to ask. So associated symptoms. Does anyone want to take a gander? No, you know what? Let's not do that. We want to maybe ask also social history. And here's all of his information from Mr. Murray. So I forgot some of my own history, which is my bad. So I do have diabetes, and I also have GERD, or reflux disease. My dad had a heart attack when he was 55. My mom is alive, but she does have diabetes. I had an appendectomy in childhood, but I don't like going to the doctor. Haven't had any other surgeries. And I've been smoking for 40 years. For those of you who don't know, this is something that you'll see a lot of the vernacular. Pack year smoking is one of the ways to characterize how much people have smoked. So 1 pack a day would be, so 1 pack a day for a year is 1 pack year. If I smoked half a pack a day for 2 years, then that would be the equivalent of 1 pack year. I don't know if that math makes sense, but so since I've been smoking 1 pack a day for 40 years, that makes me a 40 pack year smoker. And you can, there are some different risk factors and risk calculators that are based upon what your pack year smoking is. So that's just a little factoid for you all. I'm a social drinker, and I take metformin and Zofran, which is for respectively my GERD and my type 2 diabetes. So someone let me know when you're done putting this in your SOAP note, and we'll move on to the next bit of the case. Any questions so far? Cool. All right. Thank you, Matthew. So moving on to the physical exam. Does anyone want to interpret what we're seeing here? Maybe that was too open-ended of a question. So temperature, I'm afebrile. My heart rate's kind of high, but I'm not technically tachycardic. That would be, where's the line between regular heart rate and tachycardia? 100, perfect. My BP is a little high, might be stressed, might be in pain, might be just an unhealthy guy. Respiratory rate's borderline high, so I'm breathing kind of quick. And my O2 sat's a little low, but it's nothing awful, but it's a little low. We'd love to see it closer to 98. I'm in moderate distress, just kind of sitting up in the chair, huffing a bit. I've got an S4 gallop. We can talk about that in a second, but no rubs. And my PMI is just placed laterally by 2 centimeters. got some diffuse crackles in my lungs and 2+ pitting edema bilaterally. If we want to go into this a little bit more, since this is a heart lecture, does anyone know how we would call the normal heart sounds if there were nothing abnormal here? So I'll say that the S4 gallop is an abnormal heart sound. Does anyone want to take a gander at what normal heart sounds are? How many are they, and what makes those sounds when we're auscultating the chest? It's a tricky question. Lap dap. Good. Yeah, so there are two sounds, that's correct. We call them S1 and S2. And yes, you're absolutely right. The closure of the valves make these sounds. Lub dub is a perfect answer. There are two sounds, and yeah, that's very close. So the S1 sound is made by the mitral and the tricuspid valves closing, and the S2 sound is by the aortic and the pulmonic valves closing. So it represents the two phases of the heart. Systole being when the heart muscle contracts, and diastole being when the heart muscle relaxes, and the valves will open and close respectively. So we call those S1 and S2, and we have two kind of advantageous heart sounds, those being S3 and S4. They're not always pathologic, but a good way to remember it is if you hear an S4 gallop, which comes just before S1, which is just before when the mitral and the tricuspid valves close, then that is usually indicative of, no, actually I can't say it because we're about to build a differential. Never mind, don't Google it in the meantime. PMI being laterally displaced by 2 centimeters. So I'll tell you that the PMI means, since the heart is kind of like in the chest cavity and it kind of like leans forward towards the front of the rib cage, the PMI is going to be a place, you can probably feel it on your own chest. It's going to be down from the mid-clavicular line, the middle of your clavicle on the left side. If you go straight down to like your 4th or 5th intercostal space, which is going to be kind of right at the end of the sternum, you can usually feel your PMI. It should be kind of in the mid-clavicular line in the 4th or 5th intercostal space. And that's usually where it should be. Does anyone have a theory as to what might cause the PMI to be more lateral or more to the side on the chest wall when we're feeling for it? Cardiomegaly, yeah, that is an absolutely great theory. So, yep, if the heart is bigger in the chest, then that point where it kind of pushes most on the chest is going to be pushed more to the side because the heart kind of like leans forward and it's kind of this weird egg shape. And then we have diffuse crackles in the base of the lungs. This is kind of vague, and it can be, someone brought up COVID earlier. So having crackles in the lungs can mean a number of things, and we're going to talk about the pathophysiology behind this. And we also have pitting edema in the feet. Does anyone know what pitting edema means? It's a very specific type of swelling in the legs. So when you press on the skin and it makes a dent. Yeah, pretty much. So we have 1+ and 2+. 2+ is quite bad. And so we press into his, like right on the front of his shins and on his feet, and it just kind of stays in there. So we can talk about the pathophysiology for that as well. So that's another hallmark sign. So follow-up studies to consider. So given this is the way Mr. Murray has presented, he's still wheezing on your exam table. This was our physical exam. What do we want to do next with him? In terms of labs, in terms of imaging? X-ray. X-ray is a great one. What might we look for on the X-ray? Yeah, perfect. We want to do an ECG. We want to do an echo. That's a great one. Anything else we want to order for him? I like all of these imagings. I agree with all of these. Tropes, yeah, we can get tropes for sure. Typically, classically, what does elevated troponins represent pathologically in a patient? Not always, but yeah, usually in MI. But we can also get elevated troponins, Matthew, from just what we call demand ischemia, meaning that like if your heart rapidly has to start pumping a lot harder, that can stress the myocytes out enough that they can break and they can release troponins into the blood. And that's when we can see elevated troponins not in the setting of an MI. So it's not always an MI, but typically it is. And I agree that we want to check tropes on this guy. And there's a couple other markers in the blood. So we typically get a CBC and a CMP, meaning we get a blood panel and a metabolic panel on mostly everyone just to check electrolytes and a couple other specific markers that we don't need to go into. So here is Mr. Murray's X-ray and his EKG. I have done a session on reading EKGs, so I'm not going to go into exactly all of this right now because it's beyond the scope of this particular talk. But does anyone want to comment on maybe the chest X-ray first and tell me what they see? I'm not a radiologist, nor do I plan to be, so I'm not going to get into the nitty-gritty, but just looking at it. Yeah, cardiomegaly, a good rule of thumb is it shouldn't be more than half the chest. If you were to look at it, and if you were to grab like a caliper, the heart should not take up more than half of like the chest, and here it super does. So this is a big heart, which would be why his PMI is displaced to the side. Anything else? Deep P waves. We do see deep waves. This is not technically the P wave. P waves are these little guys. Where's a good P wave? P waves are going to be like these little guys right here, right before the QRS complex. What we do see deep, these are going to be R waves. So we do see deep waves here, and that is definitely important to note. I think you noting the amplitude of these waves is super relevant to his what he's presenting with. So that's absolutely right. Anything else about this chest X-ray? You're not expected to know how to read a chest X-ray, by the way. Infiltrates in the lungs. Devani, correct. So we're seeing, this is kind of like cloudy, something or other, like lungs should be full of air. And so they should be pretty, they should look more like this, and they should be more, more with air. And so these guys being cloudy like this would be why he had the crackles in the lungs. So the main things I wanted to note here was this guy's got a really big heart and his lungs look kind of congested. We don't know what this congestion is at this moment, but I'll just say that when we're building our DDX, something like someone had brought up pneumonia or COVID pneumonia or something like that. Typically pneumonia is not gonna like uniformly affect the lungs like this. We might see like one patch or something here or here or here or something. Some pneumonias can present looking like this, but given this guy's other symptoms, I would think it was less likely. And someone mentioned an echo, which I absolutely think that we would get on this guy. I didn't put an echo here because echoes are dynamic studies and I don't know how to put a GIF in Google Slides. So I'm sorry. But yeah, I do want to say that this is representative of this ventricle, his left ventricle being enlarged. It's called left ventricular hypertrophy. And there are very specific criteria, like this wave being greater than 11 millimeters, for instance, is one of the 3 criteria for left ventricular hypertrophy on an EKG. So that's what we're seeing here, basically. As Matthew noted, we're seeing very deep waves in these leads. These leads, an EKG takes a picture of the heart. So these leads represent basically this part of the heart over here, having a thicker wall. It takes longer for the electricity to conduct through the heart muscle, which is thickened. Therefore, that's why these waves are longer. And so we can see this. It's a cool way to take a picture of the heart. Oh. All right, so now let's build our DDX. What do we think this might be? Unfortunately, this is a lecture about heart transplant, but let's pretend it's not for a second. Yeah, okay, so CHF is a great one. And we're saying congestive heart failure because his lungs look super congested. So that's a great one. I would put that high on the list. Anything else? COPD is a great one, especially what about the way he presented, or maybe look back at your SOAP note. Why is COPD a really good diagnosis to consider for this guy? He's a smoker. Yeah, he's been smoking forever, this guy. Not forever. He has a 40-pack year smoking history, which is pretty significant. That's a good one. His chest, yeah, I mean, his lungs sounded really bad. So considering, making sure to remember that the heart and lungs are like a married pair. And so really considering diagnoses, like a lot of lung pathologies can affect the heart and a lot of heart pathologies can affect the lungs. And so just keeping in mind that just because we've kind of anchored on this being a cardiac problem doesn't mean that we should be excluding lung problems as well. Anything else we think this could be? Cardiomyopathy, yeah. So this is definitely some type of, this guy's got, so things you might consider for that would be like a viral dilated cardiomyopathy. Could be his heart was quite large. There is a difference between like a restrictive cardiomyopathy and a dilated cardiomyopathy. Has anyone heard of that before? It's okay if not, I'm just throwing stuff out. I don't want to go over stuff that you guys all know already. Arterial plaques or atherosclerosis, sure. I mean, he did have some exertional difficulty with breathing. So I think especially considering his diabetes, he's got GERD, which might mean that he's obese. And so it's definitely possible he's got some plaque buildup, especially if he's got poorly controlled diabetes. That's a great thing that he might have as well. So we did want to check his tropes and we did want to check his EKG to make sure that he wasn't showing any evidence of coronary artery disease for sure. Oh yeah, does any restrictive versus dilated cardiomyopathy? So basically the heart can respond in two ways to stress. It can either, the muscle can either thicken or the muscle can dilate out. And both of them can look like that large heart that we saw in the x-ray. We're actually going to talk about this when we talk about the pathophysiology of the disease, so I won't get into it right now, but cardiomyopathy is a great kind of blanket term to talk about just disease states of the heart. Anything else we think this could be? Left ventricular failure, maybe, since his left ventricle is enlarged on the x-ray. Yeah, for sure, for sure. These are all similar ways of saying kind of like this guy's heart is not working optimally. But since the left ventricle is kind of like the quarterback of the heart, I don't know, I'm trying to learn football. It's like the main ventricle of the heart, and it's the one that pushes the blood up into the aorta. It's the first, not the first one, it kind of is the first one that it's the one where we see most of the pathology because it's quite large. And it's kind of like it's the main player of the heart. And so that left ventricle, kind of like I was hinting at before, can respond to disease states of the body by either kind of like when you do too many bicep curls, your bicep becomes large. In the same way, the heart muscle can become large, which will make the chamber itself to hold blood smaller, which means that you're going to be pumping less blood into the body systemically, which can have a lot of downstream symptoms. Or if we're pooling too much blood into the left ventricle, like a balloon being filled with water, the left ventricle can actually stretch out and the wall will become thinner. And that's called dilated cardiomyopathy. And that's another form of left ventricular failure. So because it's like if I didn't do bicep curls and then my bicep muscle like kind of went away, it's going to be less efficacious at pumping the blood out into the systemic vasculature. And so similarly, that can lead to fatigue in these patients if it's not functioning, either because the chamber itself has become small because the muscle is thick, or because the chamber has become too large and now the muscle is too thin. Yeah, great job, everyone. So I put these COPD, heart failure, and other, which is a cop-out on my part, and interstitial lung disease, just because he had really ugly looking lungs on the chest x-ray. It's less likely to be that, I think, just based on his other symptoms. So assessment and plan, as we said, this is going to go into your SOAP note as well. So the way that I like to do an assessment and plan is I like to kind of, usually I'll put like 1, 2, 3, 4, and I'll put every problem that the patient comes in with here, and I'll list them. So the main problem he came in with is shortness of breath. What could be causing that? We're thinking probably like heart failure versus COPD versus lung disease. So then my plan, because assessment and plan is kind of like one big thing, is going to be to kind of, let's figure out how we're going to work this up. What is the way that we're going to parse through whether this is heart failure or COPD or lung disease? And we've done part of that with the EKG and with the chest x-ray. That was one of the ways that we can start parsing through. Echo had been brought up, which is actually going to be our mainstay way to see if this is in fact heart failure and what the severity would be. I am the cardiologist. I don't know why I'm consulting with myself. And then given the EF being so low, we are also going to consult with cardiac surgery. And we'll talk about that in a second. He's got that pitting edema, so we might consider some diuretics for him just to try to get some of that water out. Because it just means that he's got the fluid has extravasated from his vasculature and is now pooling kind of beneath the skin, and that's why his feet are pitting. We got to make sure he's being compliant with his medication for his diabetes, and we want to counsel him on smoking cessation. We have to. Any questions or things that you want to add to the assessment and plan? This is by no means an all-inclusive assessment and plan. This is just kind of off the top of my head. If you guys think anything needs to be added, anything you would like to add to the workup, or if you have questions about anything that I've written here, except for the cardiology consult, I recognize that that was stupid. Gucci. Alrighty, let's move on. So now we're going to talk about heart failure because this is closely married to heart transplant, and we can get into a little bit more about the surgery itself after I think we hammer down the basics of heart failure. So heart failure, there are two main flavors. There is reduced ejection fraction and there is preserved ejection fraction. So reduced ejection fraction, this is kind of what we were talking about a second ago with the restrictive cardiomyopathy versus the dilated cardiomyopathy. Given that this is a reduced ejection fraction, does anyone have a theory for whether this would be the restrictive cardiomyopathy or the dilated cardiomyopathy? Just a theory based on what we've talked about. Less output may be restrictive. Yeah, so we are seeing less output. We see that actually as a similar thread between both reduced and preserved ejection fraction, but absolutely we do see reduced output. I am going to agree with Sanjana that it is dilated cardiomyopathy. Do you want to take a gander? Sanjana, since you were right, I don't want to pick on you, but maybe why did you think dilated versus restrictive?
Should I speak?
Absolutely. Yeah, go for it.
I was saying because of the edema, and also because of the cardiomegaly. So that's just my guess.
No, I think that you're pointing at two really great hallmarks of heart failure. It's going to be that pitting edema and the large heart on the X-ray. So let's talk quickly about the pitting edema since you talked about it, since that is one of these central things that, like, when, for instance, when we're going to look at patients who we are suspecting and we're trying to parse through, is this COPD or is this asthma or is this heart failure, we're going to go right to their legs and we're going to press into their shins. Does anyone know, just off the top of their heads, maybe why we might be pooling fluids in the lower extremities in the case of heart failure? It's okay if not. It's kind of an evolved topic. It's cool if not. All right, I'll just talk about it, since this is certainly a concept that is going to come up in your medical careers. It's an important concept to understand. Because the heart did not do its work and the blood stays in the veins. Yeah, you know what? Actually, that's pretty much it. So heart, blood returning to the heart comes into the right side of the heart, which is going to be into the right atria, which then goes into the right ventricle, which is then pumped into the lungs. And so this blood, if the heart is not contracting properly, for instance, in a case like this of dilated cardiomyopathy, where the heart muscle has become thin and weak and cannot pump effectively, blood is going to pool in the left and right sides of the heart, and it's going to kind of expand like a balloon being filled with water. That being the case, the inferior and the superior vena cava, which come into the right atria from the top and bottom, feeding venous blood from the head and arms and also from the torso and the legs, that blood, because it's not being pumped through the right heart and into the lungs, is going to pool in the right side, and it's going to back up into the inferior and the superior vena cava, which you can actually see sometimes distended neck veins in these patients because the blood is pooling up, but because gravity pulls down, we're going to see a lot of that blood is going to be in the inferior vena cava and pool even further in those legs and feet. And if we see a ton of blood in the legs and feet and just a lot of kind of static blood that's not moving as it should, some of that fluid is going to extravasate from the veins into the interstitial space, and that's why we're going to start seeing that fluid pooling in the legs and feet, which is why some heart failure patients will wear those compression socks. So that's an important concept to understand. So yes, back to this. This is reduced ejection fraction. We're seeing reduced contractility and systolic. Systolic is when the heart contracts. Systolic ventricular dysfunction. We see decreased ejection fraction. Ejection fraction is basically how much blood is being shot out of the left ventricle and through the aortic valve into the aorta into the systemic circulation. So we're seeing decreased blood basically coming out of the heart. Theories about what that might cause if we're seeing if less blood is coming out of the heart, we have reduced ejection fraction, we have reduced cardiac output. What might that cause just in terms of symptoms as a result of not getting enough blood out of the heart? Lower O2 sat, yes, for sure. Because the blood carries oxygen, we can definitely, that might be one of the reasons, this very astute, that his O2 sat was just a hair low. Shortness of breath is a great one. And part of that is also, so part of that is that he's got all that edema in the lungs. The pathophysiology of the edema and all those crackles in the lungs and that really ugly picture we saw on the chest x-ray is the same pathophysiology that we saw for the pitting edema in the legs. Basically, we're seeing blood build up in the lungs and it's not moving like it should, and then the fluid extravasates and creates that cloudy picture in the lungs. We can see syncope, which is a really great one, Sanjana. If we're not getting enough blood pumped out, not enough is going to go to the brain. And if not enough goes to the brain, then the body's like, oh, I should probably be horizontal so gravity can help me get more blood to the brain. And then you pass out. So that's a good one. Dizziness is another great one. We can see this also if we're not getting enough perfusion to the brain. Muscle fatigue, perhaps, if we're not getting enough, again, oxygen into those muscles. We're going to see not enough blood going to a lot of the essential organs. And so we might see blood markers of organs not functioning optimally as well. So that's kind of, that's good. Yes, that is what we're going to see from decreased cardiac output. Now, we're also, this is kind of going into some of the reasons we can have this dilated cardiomyopathy. We can have, like, there are viral causes that can cause your heart to do this. If you have a myocardial infarction, sometimes those cells can become ischemic, damaged, and thin, and this can cause that particular wall of the heart to not contract properly because it is fibrosed and ischemic. And this can cause a reduced ejection fraction as well, just because imagine that it's a concentric muscle. The ventricle is like like a little pocket. If half of the wall isn't contracting properly because that muscle is dead, then you wouldn't be pumping blood efficaciously from the ventricle. Arrhythmia, what is an arrhythmia? Abnormal pace. Yeah, pretty much. So it's the heart not, since the heart is the heart contracts via an electrical conductance system within it. If that system becomes damaged or is just aberrant in general and does not function the way it should, We can see various arrhythmias. You've maybe heard of atrial fibrillation or like VTAC or VFib or AFib. These are all examples of various arrhythmias, or basically quite literally the rhythm of the heart has been disturbed. So if the heart is kind of fluttering and like fluttering rather than contracting uniformly, that can also cause the heart to not pump blood out. And then high output conditions, we won't go into it. It's a whole other thing. So now we have heart failure with preserved ejection fraction. We have reduced compliance, which means it's not relaxing properly, because this was the example of the bicep curls. That ventricle has just become super thick. So now versus with reduced ejection fraction, we are now seeing diastolic, which is when the heart relaxes, ventricular dysfunction. And this is because if the muscle is really thick, it cannot relax enough to create a large enough chamber to like what would have been normal if that chamber had not become too thick. So it's basically not able to relax because it's so large. I hope that makes sense. So we're not able to fill the ventricle adequately, meaning we're not able to hold enough blood in that left ventricle, basically. And then that is similarly going to lead to a decreased cardiac output, just because we're holding less blood in the chamber because there's less space. So if we had increased stiffness of the ventricle from long-standing hypertension, we can see the ventricle become large. Now, does anybody have a theory as to why hypertension in the body would lead to this particular, this kind of restrictive cardiomyopathy, thickening of the ventricular wall? Why might we see that in hypertension? Perfect. We see increased afterload. For those of you who don't know, afterload is basically like how much force does the heart have to push against to get blood out. So one of the ways that we can increase the afterload, which is basically like the resistance of the fluid system that is the heart and vasculature past the heart, as soon as we pump from the aortic valve out into the aorta and the rest of the body. So if that system becomes higher pressure from atherosclerosis or whatever, then we have larger force to push against. And like a person who's doing bicep curls now, instead of with 20s, with 40s, I have more to push against. That muscle is going to become much larger. That's great. And then impaired relaxation of the ventricle. So the pericardium is that sac that surrounds the heart. And so if something were to happen to that sac and it became fibrosed and was not as basically compliant around the heart, it would cause it to not basically similarly be able to relax, because it would be too confined by that like thickened pericardium around it. Or if we get blood pooling between the heart and the sac that it's in, the pericardium, that can similarly kind of compress the heart and cause it to not be able to relax in diastole as well. Does all of this make sense? The reduced versus the preserved ejection fraction? It's kind of hard to visualize. That's why I'm trying to hammer it home. Questions, comments, concerns? Okay. Thumbs up. Awesome. So we talked a little bit about this forward failure, basically. So I won't go too much into it, but if we have, as you had all talked about, reduced cardiac output can lead to organ perfusion going down. We might see hypotension similarly. So actually, this is an interesting point, that this is why someone who had developed cardiomyopathy secondary to hypertension could actually have a normal looking blood pressure, because they have hypotension, or they're pumping less blood out, which would lead a normal person to be hypotensive, but because at baseline they were hypertensive, it kind of like averages out and they can actually present with a pretty normal blood pressure, which is scary. The most sensitive organ in the body is the kidneys. So looking for those markers in the blood of kidney dysfunction is a great way to kind of look at the severity of someone's having poor perfusion, possibly secondary to heart failure. I like that you guys targeted right in on the brain. For sure, someone having dizziness, fatigue, or syncope or passing out, that can be a dangerous hallmark of poor perfusion to the brain. Backward failure is what we were talking about before with that cardiogenic pulmonary edema, which is what we saw on that chest x-ray, which is when we get the orthopnea. And also when we get that peripheral edema, which is going to be in the legs, but can also cause congestion of some of those other organs with a really complex venous vasculature. But we don't need to get into the liver and stomach because I'm not a big fan of them. Oh, I guess I didn't insert a graphic there. Okay, so now we're going to work this guy up for heart failure because we've determined he has it. We have talked about it ad nauseum. So we have a couple markers. I know Matthew had mentioned troponins. Another great marker for heart failure in particular is this one called BNP. Sometimes they call it proBNP. But this is the main one. A lot of people will like call this the heart failure marker. And this helps us to see kind of how severe the heart failure is. Basically, the heart, the ventricles will release this enzyme if the heart muscle is basically not functioning optimally. It's not really similar. It's not really the same as troponins, because troponins is more like the cell has like died and lysed because it's ischemic. This is more like the heart is stressed. And the heart is in the process of failing. So we need to see, in a lot of patients, we'll be checking their proBNPs to see if they are grossly elevated, which can be a hallmark of heart failure. We don't need to get into the nitty-gritty of that. And now we get into diagnosing it itself, which I know you're going to be like, this is what we've been doing the whole time. But this is really how we get into diagnosing it. So someone had mentioned a cardiac echo before. There's a couple different types of echoes. We can go right from the thoracic cavity and put it right on the chest wall. We can do one from the esophagus. We call that a transesophageal echocardiogram. And so there's a couple different ways to get views of the heart. This is a great way to image, though. This is a dynamic picture of the heart as it pumps. We can even put a Doppler on, which will show how much the directionality of the flow of the blood in the heart. And this is great for us to actually calculate what that ejection fraction is coming out, because these machines can calculate how quickly the blood is going out from the aortic valve into the systemic vasculature, how large the aortic valve is. And most importantly for heart failure, we're going to be looking at the ventricular wall, which can either, like we talked about, be super thick or super thin. And we can look at the ejection fraction is calculated mostly based on how much is the wall of the left ventricle contracting and how uniformly is it contracting. It's a concentric muscle in a kind of in a circle. And so if only half the wall is contracting, what might cause only half the ventricle to contract? Or only a part of the ventricle to contract, maybe not the whole thing. Weakening of the muscle? Sure, yeah, absolutely. So weakening of the muscle may be secondary to, the most common one's going to be if you had an MI and part of that wall had died or become ischemic, that part of the muscle is likely not going to be seen contracting on the echo of that person's heart. And so we can see that, and then that will lead to a reduced ejection fraction. Conduction pathway failure, absolutely. This is another great thing to see on echo. You can actually see the chambers fibrillating if a patient's in AFib. And if we have advanced conduction pathway failures, we may see usually like a discoordination of the atria and the ventricles contracting. And if you have really damaged pathways, perhaps we can actually see differences in the way the chambers themselves contract. Yeah, that's a great one. So we're looking at the systolic dysfunction, systole again being when the heart muscle contracts. LVEF is the left ventricular ejection fraction that we were just talking about. So normal is going to be somewhere between 50 and 70, and it's going to be a reduced ejection fraction if it's anywhere less than 40. And again, you do not need to know, even in medical school, you won't need to learn how to calculate the ejection fraction based looking at an echo. That's for the cardiologist to do. But basically, it's just how much are those walls contracting and are they doing it uniformly? And then, of course, we're also going to see if there's diastolic dysfunction, how large is the chamber itself to be able to be filled with blood. So when someone is diagnosed with heart failure, we're going to start with usually medical treatment. So the first thing we're going to do is treat them for their risk factors. What might some of the risk factors be? Smoking, right? We're going to say, please stop smoking. Yep, try to get up and move is a good one. The diabetes, absolutely. We want to be on him to be taking his metformin and make sure that his regular finger stick glucose, make sure his glucose is under control, absolutely control his hypertension. And that, Devani, leads right into our stage B treatments, ACEs, ARBs, and beta blockers. These are all, actually all of these too, these are some of the most common drugs to be used for hypertension or high blood pressure. I don't know if we need to go into the mechanisms of this because it's getting very into talking about the renal system, which is a whole headache. But basically, lisinopril is probably one you've heard from here. Lisinopril, enalapril, metoprolol would be the main one you've heard of from here probably. And these are drugs that we might try next to try to lower that blood pressure, as was mentioned, to decrease that afterload a bit and make the heart, give the heart a little bit of an easier job. Lipid panel correction is a great one. Yeah, since this guy probably has obesity, we want to make sure that his lipids are being well controlled. And we might do a lipid panel on him. If he had really high cholesterol, we might start him on a statin drug, like a torvastatin or rosuvastatin. You might have heard this called Lipitor or something like that. That might be a drug. That's not part of his heart failure treatment, but certainly that's a way to help control the risk factors, absolutely. Aldosterone agonists and diuretics are another great way to help blow off some of that extra fluid that he's pooling in his lungs and legs. So the main one you might have heard here is Lasix. Hydrochlorothiazide are the main ones that you will have heard of from this probably class. And then finally, if we get to stage D and he's kind of not improving after all of these, we're going to start just treating him symptomatically, because the drugs that we would use, there's no drug, unfortunately, to reverse the pathophysiology of heart failure. As we're saying here, cardiac transplantation is the only real way to cure end-stage heart failure. So if we reach this point, we might consider transplant. So now we finally come full circle to the main part of this. So quickly, the way that end-stage heart failure is not an arbitrary designation. There are NYHA classes for this. This is the indication for cardiac transplant, NYHA class 4, the classes are all listed here, and an ejection fraction of less than 20%, which is quite low, normal being closer to 50, 60, 70. So that would put our guy basically here if he were a candidate for heart transplant, meaning he cannot move at all, he's sitting in his easy chair and he's already wheezing. And then we do the echo and the ventricle is hardly contracting at all. So because heart failure is such an advanced topic, this is mostly what I have on the slides. And then I thought maybe I would just sit and answer whatever questions you had about heart failure or about cardiac transplantation itself or cardiac surgery. Because the topic is so advanced, and I thought it was more important to kind of go over what the steps are leading up to cardiac transplantation. And so why would we even need to get to the point of transplanting a heart? Because really, you're not even gonna, unless you go out of your way to see it, cardiac surgery is not gonna be part of your general surgery clerkship in medical school. So it's kind of that thing that you have to go seek out for yourself if it's what you really enjoy. And so you're not really going to get into the nitty gritty of seeing cardiac transplants unless it's something that you seek out to do yourself. So, but the things that you will be seeing in medical school is this about heart failure. So I thought it was more important to focus on that, but I want to take the rest of the time here to answer questions you have about anything we've talked about today, about the SOAP note, about the quiz, and about cardiac surgery or cardiac transplantation. So I'll just leave the door open for you guys to ask questions about cardiac surgery, or I can pimp you guys with more questions about, I can pimp you with questions about cardiac surgery if you want to do it that way too, about some of the nitty gritty of it. Your call. Could patients classified as class 3 heart failure be eligible for cardiac transplantation, or is it just class 4? It's typically just going to be class 4. The criteria may differ, and it's not just like if you're class 4, but if you're like very ill and you're 85 years old and bedbound, and you've also got like liver cancer, like remembering that these patients don't exist in a bubble, and typically if you've gotten to the point of having end-stage heart failure, you have other comorbid conditions. And so, yes, I can go back to that slide. So we can, it all really depends, but typically they need to be quite severe. We're not just going to throw a new heart into just anyone. But it is a good question. These criteria are all very, these are my sources, are all very specific. Backward failure right here. I hope that answered your question, Bridget. Put in your place is pimping. Yeah, that's what pimping is. I don't mean it to put you guys in your place in that sense. Pimping is just the word that we use. But I learned by being asked questions. And so if you guys want, sorry, Stephanie, if you guys want to be, in Canada, it's at least stage 1, stage 3, or stage 4. Okay, I didn't know that. I learned something new today. Thank you, Matthew. But yeah, so I forget what I was saying. Oh, I learned by being asked questions. And so like, I know when I've been in the operating room for cardiac procedures, there are some like questions that they ask about like induction, like how do you stop the heart? You know, what does the heart lung machine do? And so if you guys want to talk about that too, I'm happy to talk about that. I mean, does anyone know? So when we go in for these cardiac transplantations, we do need to hook these patients up to bypass or a heart lung machine. Does anybody, just based on the physics of the heart, the problem is this involves kind of a complex understanding of the anatomy of the heart, but why not? We're all here. Does anyone know where, so when we do I'm sorry, I keep starting questions and not finishing them. When we're starting bypass, we need to put conduits in to represent like, because it's taking over the job of the heart. So does anyone have an idea about where in the heart or in the neighboring vasculature we would put those conduits for the heart lung machine? Like for instance, the one that's going to represent the left ventricle, if I'm about to take out the heart and the heart lung machine is about to be my new heart, where would the line that's going to pump blood out into the systemic vasculature go? I don't know if that question makes sense. I hope that makes sense visually. Aorta. No, perfect. You're right. Yeah, so we're going to put one in the aorta, and that's going to be my forward flow conduit. And then, yeah, the other one's going to go into my large venous structures. Perfect. So that's exactly right. And that will help me to kind of get that heart quiet. And then does anyone know what we use to actually stop the heart and maybe what that's called? These are really hard questions, by the way. I would be very impressed if anybody knew these. Oh yeah. So this question is, how do we stop the heart and what is the process called? This is a morbid connection, but if anyone knows like how they kill patients on death row, this is one of the substances that they use for that to stop the heart. It's not a defibrillator. That's a great question. That's a great one though. Adenosine is another good idea. We actually use that to stop some various arrhythmias that could be quite deadly. It's potassium. Yeah, exactly. So we do give potassium to patients on death row, and the function of that is to stop the heart. Basically, it sends your heart into VTAC, which is a dangerously fatal arrhythmia. And then your heart basically fibrillates and then stops functioning and you die. And so we inject potassium into the heart. In this process, does anyone know what the process is called? True crime documentaries. Yeah, exactly. It's called cardioplegia. So the surgeons will say we're going to induce cardioplegia. And there's actually two ways. Because we want to do this effectively and we don't want to be awful and torture these poor sleeping patients. We actually induce cardioplegia from two sites. We call this anterograde and retrograde cardioplegia. And so maybe you guys will know this too, because this is a very smart group. So if we're doing anterograde, which is forward flow cardioplegia, we want to get this potassium to spread through the heart as quickly as possible. Where do the arteries that supply the heart, like the ones that get blocked in a heart attack, the LAD, the PAD, the circumflex, where do these all stem from? Just intuitively. Where do the arteries, yeah, these coronary arteries, exactly, that's what they're called. So the coronary arteries, the LAD, the PAD, the circumflex are the main ones. They all come from the aorta. So our anterograde cardioplegia is actually going to be injected kind of right at the base of where they come off the aorta, and that's going to be able to spread that potassium very quickly arterially, and that's the forward flow. Now the backward flow, or the retrograde cardioplegia, is another type of cardioplegia that we do. And does anyone have a theory as to where we would inject the retrograde cardioplegia for backward flow to kind of, just an aside, my sub-note quiz this week is the same as last week. Oh, is it from the link that I sent?
Oh, no, not from the link that you sent, but if you go to the soap notes for like kind of through the session, like kind of the thing that has like the summary of sessions for today, that soap note has the questions from last week. But if you do the link that Jackie sent throughout the presentation, you should be okay.
Thank you. Yeah, I'm sorry, everyone. I don't really know what the logistics of these are, but yeah, sorry for the confusion. But yeah, so the retrograde cardioplegia, does anyone have a theory for where we would inject that, given that anterograde cardioplegia? Yeah, basically the coronary veins. So our main vein is called the coronary sinus, and that kind of sits right behind the right side of the heart. So we're actually going to induce cardioplegia, anterograde and retrograde at once. And that will rapidly stop the heart and allow us to go completely onto bypass. And it's a really cool moment. These are questions, by the way, that you will get pimped on if you ever see a cardiac surgery, and everyone will be wildly impressed if you could answer them. And this is the moment when you look at the big monitor on the wall and the patient goes into asystole, and it's super cool and the heart stops, and then they like throw a bunch of ice on the heart and it stops, and it's the coolest thing ever. Like I said, cardiac surgery is not built into the general surgery curriculum really at all. And likely will not be a part of your clerkship. So if you're interested in cardiac surgery, do take the initiative to ask cardiac surgeons to see some of their procedures. Yeah, I think it's cool. It's my favorite thing in medicine. So I'm biased, but if you are, sorry, I'm getting a call. If you are able to see one, I highly recommend it. I think it's something I recommend everyone try. So any questions about cardiac surgery or heart failure or anything before we all leave one another? I'm happy to stay in chat. Cardiac surgery is my favorite topic, but I didn't want to overwhelm and talk just about next week. Oh, by the way, for everyone here, next week is LVADs. I don't know if anyone here is a Grey's Anatomy fan or if I'm the only one who likes trash soapy TV, but Denny Duquette had an LVAD and he had his LVAD wire cut. If anyone here is a Grey's Anatomy fan, yeah. So if you're interested in learning more about why he had an LVAD and why having the wire cut was so bad, then tune in next week for the LVAD talk. And you'll have a leg up on some of the other people as we kind of talk about a lot of the reasons why he had an LVAD placed were similar to this. And a lot of times we use an LVAD as a bridge to cardiac transplant because not everyone can get a heart. So I hope that, do they make a transplant? How do they make a heart transplant heart to work? So this is a very complex question. So it's not, the transplant itself is really not that complicated of a procedure. You cut in all the places where the heart is connected to the body, take it out, and then you sew everything back together, essentially. All of the places, the inputs and outputs of the heart, we sew them back together. Now, getting it to restart, we make sure that the potassium is washed out of the heart. If the heart is not starting, we can use an internal defibrillator, which is these two little paddles that you actually put directly on the heart, and you can shock it with low voltage joules. And those low voltage joules, I don't think is a sentence that makes sense, but we shock it at a very low voltage, and that can restart the heart. It's kind of like, it's not, I don't want this to be confused with a defibrillator, because you cannot defibrillate asystole. This is something perpetuated by medical dramas and a lot of people. That's just false. So you cannot shock a heart that's not working to start again. You can only shock an abnormal rhythm like VTAC, which we talked about, or VFib, which are fatal. You can shock those, but you cannot shock an asystolic heart. So we would have to kind of get it started. You can do some manual heart massage, which is kind of where you put your hand directly on the heart muscle and kind of massage it to kind of get all the juices flowing and kind of get it to start to work. But yeah, so that's kind of how we do it. And then if usually it will start and then kind of freak out and it's like, oh my God, why am I awake? And then you can shock it then when it kind of like wakes up and isn't beating properly because it's in a new home, and then you can shock it. But I don't want anyone to walk away from here thinking that you can shock an asystolic heart. False, 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 false. Call all your friends out when you watch your medical dramas. And then of course we have to make sure that they're immunosuppressed. And we have to watch them closely for opportunistic infection following the transplant, because having someone else's tissue in your body can cause you to, you don't want your body to reject the heart, basically, is the second. Putting the heart in is the least of their problems. You guys learned something. I hope that it wasn't too rambly. And I hope that I can see some of you guys next week for the LVAD talk.